Hi, hello everyone. Today we will discuss kidney pathology, few MCQs. First one is Casts seen in acute glomerulonephritis, highly granular RBC WBC. Answer is RBC.
RBC casts, WBC casts and epithelial casts are cellular casts. RBC casts appears orange red and their significance is they are pathognomonic of glomerulonephritis RPGN and they are the indicator of bleeding within the nephron. RBC casts can also be seen in IgA nephropathy, lupus nephritis, bacterial endocarditis and renal infarction. Coming to WBC casts, these are the casts with WBC within the protein matrix and their significance is they are seen in pyelonephritis, tubulointerstitial disease. They can also be seen in glomerular diseases, lupus nephritis and interstitial nephritis. Now coming to epithelial casts. These are the casts with tubular cells within the protein matrix and their significance is they are seen in acute tubular necrosis, viral infection, CMV, heavy metal, salicylate, poisonings. Next question. Dash is seen in post-streptococcal glomerulonephritis. Option A, epithelial humps. Option B, spike and dome appearance. Option C, mesangial deposits. Option D, subendothelial deposits. Answer is epithelial humps. In post-streptococcal glomerulonephritis, if we see the time course, it will be 1 to 4 weeks after the streptococcal infection, sore throat or pyoderma. And the age group most frequently involved is children from 6 to 10 years of age. And the inciting agent is group A beta hemolytic streptococci. And the nephrogenic strains are 12, 4 and 1. Decreased C3 complement levels and increased anti-streptococcal O ASO titer, normal levels of C4 are the characteristic features of post-streptococcal glomerulonephritis. Coming to the morphology, on light microscopy, you can see hypercellular glomeruli infiltrated by WBC and there is proliferation of endothelial and mesangial cells, endo and exocapillary proliferation, and in severe cases there will be crescents. And on immunofluorescence microscopy, granular deposits of IgG and C3 are seen in the mesangium and along the GBM. Coming to electron microscopy, discrete amorphous electron dense subepithelial deposits or humps are seen. Prognosis, in children, self-recovery is seen in 95%, that is good prognosis. 1% become severely oliguric and develop RPGN. 5% undergo slow progression to chronic glomerulonephritis. Prognosis in adults, 60% of the sporadic cases do recover promptly. Other will progress to RPGN or chronic glomerulonephritis. Next MCQ. Most common cause of nephrotic syndrome in children. Option A, membranous glomerulonephritis. Option B, minimal change disease. Option C, PSGN. Option D, RPGN. Answer is minimal change disease. Most common cause of nephrotic syndrome in children is minimal change disease or lipoid nephrosis. And the most common cause of nephrotic syndrome in adults is FSGS and then MGN. Coming to minimal change disease or lipoid nephrosis, it is the most frequent cause of nephrotic syndrome in children and it is characterized by absence of immune deposits. It has an immunological basis. Etiology, idiopathic. Most common age groups involved is 2 to 6 years. And morphology wise, on light microscopy, glomeruli appears normal. Immunofluorescence microscopy shows no IgR complement deposits, and on electron microscopy the GBM will be normal and there will be no electron dense materials deposited. But diffuse effacement of food processes of podocytes called as podocytopathy is seen. And the proximal tubules in minimal change disease cells gets laden with lipid and protein due to tubular reabsorption of lipoproteins, so called as lipoid nephrosis. Clinical course is excellent prognosis, and 90% of will respond rapidly to the steroids. Renal function remains normal, no hypertension or hematuria. Selective proteinuria is seen. The final question, Michael-Guttman bodies are seen in option A, xanthogranulomatous pyelonephritis, option B, Malakoplakia, option C, nail patella syndrome, option D, chronic pyelonephritis. Answer is Malakoplakia. The microscopic features of Malakoplakia are infiltration with large foamy macrophages mixed with multinucleate giant cells and lymphocytes. Macrophages have abundant granular cytoplasm, phagosomes stuffed with the debris of the bacterial origin. Michael-Guttman bodies are the laminated mineralized concretions resulting from the deposition of calcium in the enlarged lysosomes, and they are typically present within the macrophages. Thank you for the patient listening.